everybody, Dr. Jay Bowen from New Jersey Regenerative Institute. So welcome back. This is part two. So if you didn't see part one of what we're talking with Leah at DataBiologics, she's the CEO, and sort of talking a little bit about how things happen in regenerative medicine and, you know, why things work and why they don't. And that's what we're going to sort of pick up from where we left off, because it's a huge topic, lots of stuff to discuss. And we're just going to sort of hit the high points, and hopefully there's some pretty interesting pearls or pieces. And if you like it, you know, type some comments below and we'll try to, you know, do maybe more videos or more content for that. So we talked about collecting real world data for disruptive technologies, specifically starting with orthobiologics or regenerative medicine for orthopedic or musculoskeletal issues in the first one. And so now I'm going to dive a little deeper into sort of the platform and, you know, a little bit more about that. So what do you see? We touched a little bit on it about this could be not just for orthobiologics, but for all of medicine. What do you see the future applications of this platform specifically for healthcare in general?
Yeah, so I mean, really the framework for what we track, it's treatments, it's conditions, it's products, and then it's a measure of success, so the outcomes that a patient reports. But there's a lot of other measures that can be indicators of success or failure of treatments too. And all of those can come in a data form. So to me, it's more about the focus of our database, and can we apply that to all areas of medicine? And every area of medicine is a treatment, a condition, a product, and an outcome. So that fits the framework for us. It just so happens that what we're trying to do is something just a little bit different than what's traditionally done with data. Typically, doctors don't have access to their own patient outcomes at their fingertips. Even the ones in academia don't have the kind of information that they actually want for decision-making and for consulting with their patients on a day-to-day basis. They're usually reserved, so these kinds of data solutions are usually reserved for what I call the administrative layer of healthcare, the people who have to bill insurance companies and be compliant with regulatory needs, or generally manage the business, manage the healthcare system. So really the physician is left in the dark, and really not getting what they want. So I think the appetite for what we're offering to a physician, specifically with how they can then use that with their patients and use that in their practice for making decisions, is totally unique. The other thing that we can do that's unique, especially in the field that we're serving right now, which is regenerative medicine, is because we've focused on more private practice and really standardizing how data comes into our system. Our platform has generated a database, and we haven't really enabled a lot of customizations and this or that. And our member base has sort of said, okay, you guys have tailored it for us. We'll take it as is. So as a result, we have a really high volume standardized data set with a lot of additional context that's coming from our experts in the field. So we're really well supported by physicians across the board. And then my own experience in working with real world data for the last 20 years, what we're now able to do is train really sophisticated AI models. AI needs clean data. You can't expect that the AIs of today would have any idea what to do with this data without our ability to structure it, clean it, and train the models so that it knows this is a good outcome, this is not a good outcome, and here's how we want to query this data set. So some of the solutions that we're building with our database are first going to serve the need for physicians to, you know, let's publish off of this data set. Let's produce clinical abstracts. Let's get a variety of poster presentations, abstract submissions for all of the medical conferences, submitting clinical papers, and even just summarizing your own practice outcomes. You know, almost every day I get a text message or an email from one of our physician members saying, hey, what's going well, and where can I improve? What other products, what do you see happening in the database? So there's a lot of curiosity about what's going on. And what we want is our AI models to be able to be very responsive to that. But it all starts from our clean proprietary data set that we can train to produce these solutions that our members are most excited about.
Yeah, I mean, sort of as an aside, one thing you sort of mentioned, just to let the audience know if you have no background on what happens in research, is you say, look at even the specific thing of PRP, is you have maybe 100 articles out there, but you can't compare across the board because everybody's using something different. So
Right.
every article maybe has 15 to 20 patients. And you say, well, let's compare 100 of them. The problem is you can't compare any of them. So it's somewhat useless, which is why, at least when we set up things, is that everything is pretty much the same outcome. So now you can compare across every different population of physicians, practices, et cetera. Which sort of leads me into maybe answering half of the same question to get your perspective is, well, some people will be on and go, this is dumb. Like, why'd you guys do this? Right? You spend money, all this effort on a company. When you have electronic medical records that were mandated by the government that have massive and tons of amounts of data, why don't you just use that? I mean, every doctor's got that at their fingertips. Shouldn't they be using that every day?
Well, absolutely. But again, it goes back to those serve the administrative layer of healthcare. It's you have to have a record. And so it doesn't matter what necessarily is like in it, but you have to have it. And it's really designed for billing, insurance, and scheduling your next order, pharmacy orders, your imaging orders, that's what it's meant for. What it's not necessarily set up to do is connect the dots between how you delivered your treatment, so the nuances of your approach, which typically are in an unstructured note. So you're just saying, this is what we did, and maybe there's a template protocol, but there is no database. You have to build a database from that information. And then on the other side of it is, there's really no way to grab, well, what was the patient's experience, unless you've built a patient-reported outcome platform on top of your EHR system. Some systems start to have that data now, but the problem is they've made it so customizable that there's almost no value from this data because it doesn't come in a standard way. And the mistake that many make when they do try to go collect patient-reported outcomes is they put too much burden on the patient. They make the surveys way too long because you try to capture everything, and therefore you capture nothing. And when we look at some of the larger nonprofit organizations that offer here's free registry, well, the response rates are under 8%, under 10%, or they don't even bother to report it. They're not getting responses because it's not convenient for patients and it's not giving doctors a direct value back. So what we've done is made it extremely simple for patients. We've optimized what that recipe is of questions that we ask every patient so that we're striking the balance between clinical relevance, things that we could publish on in the literature, and convenience and minimal time required for patients. And so that balance has actually led to, we have across the board about a 60% response rate to our surveys. And if I then narrow it down further to people who respond at baseline, so they're sort of aware from the beginning that this was the process that they're going through, it's even higher. And so that's really unheard of for an application that has very minimal human touch to create that kind of engagement with patients. And we continue to build more and more things every day that are making it even easier and more engaging for patients, but keeping that fundamental principle at front and center. It has to be simple for patients. It cannot be overburdening, and has to give the doctors really immediate value from that effort.
Yeah, I think that's something that was very interesting when we first started building this, 2019 or so, is that Dr. Malanga had a neighbor who was helping us out on sort of the computer back end, and he would tell us about his personal experience in medicine. And he was like, you mean doctors don't know their own outcomes? Because this guy worked in sort of pharma and sort of knew that. He's like, I thought every doctor knew what they were doing. And we're like, no, nobody really knows. They just quote a paper that's similar to what they do. And they're like, yeah. 80% of people get 80% better. Like, yeah, but how about your outcomes to someone like me? So I think once the patients learn that, which the audience might be like, wow, that's interesting. I thought everybody knew, that hopefully will be significantly different. And as you alluded to in our first episode, if you haven't seen it, go back and watch. It was interesting. But it's a difference, right? You have, in New Jersey specifically, and I think nationally, about last year, I think it was one of the first times we have more employed physicians than non-employed. And reimbursement's gone down for Medicare and all commercial insurers. And so there's literally patients of mine who tell me when they go to the primary care doctor that there's somebody literally pulling them out of the room if they're spending more than 4 minutes with the patient. And so patients are like, I don't really trust my doctor so much because they don't really care about me. They're just trying to get me in and out. So it's not about health or care. It's about processing people. And what we talk about is this kind of thing where we can have more of a personal concierge kind of discussion with the patient and what is best for them that allows us this interaction to really focus on what is your health, from clean air, clean water, clean food, exercise, meditation, stress relaxation. And if that doesn't get you there, then maybe an intervention like an orthobiologic or something else for a musculoskeletal issue. So, everybody's just putting the dots in on their EMR, getting in and out as fast as possible. No one thinks about it. And so that big data is difficult to evaluate. And
it's also locked up there. So there's, over 100 different EHR systems. There's two really dominant players in the market, and they serve the big giant entities that employ all of these physicians.
The hospital systems, not private people.
The hospital systems. Yeah, right. Well, now there's also private equity getting involved in owning different.
But not like private practices, right? So
right. But the challenge is even those systems, it's still the same thing. Most of what we track doesn't have a corresponding home in a structured database within an EHR system. You would have to either pull the notes out of the system and map that, or create, this medical students or, sons and daughters on their summer break. That's what we still experience is we'll go through the record and put it into a spreadsheet. And so that it's not so straightforward that, just because the doctor put it in the note, it's somehow accessible for researchers to do anything with in an aggregate form. You have to have a standard. You got to have a spreadsheet, and it doesn't create a spreadsheet. But also there are lots of, even though the regulations are pointing to these EHR systems have to make data accessible to patients, it's still very, very difficult to do. And the process for integrating and grabbing data, it's costly, it's time consuming. You need IT resources, you need money, and you need physician and staff time in order to direct the IT people about what you wanted to do. And so at the end of the day, nothing gets done because that's not feasible. So for us, it's
money,
really
right?
been
So it's not an act to make money. So just like you said, what happens is that we looked at it and said, let's proactively collect data that's meaningful, versus right now in EHRs, it's all information is thrown in there. And so from someone I know, you just mentioned that you need the physician's time to direct them because they had asked somebody in a big system. So big data, there's only a handful of people that can really evaluate big data, and they don't have a medical background. So this person, they look at it and they're like talking about essentially, an example, not the exact one, but prostate cancer. Like, what is the best thing to avoid prostate cancer or whatever? So the guys, they crunch all the data and they go, we have the absolute answer. They're like, wow, that was fantastic. And like, be a woman. They're like, well, that's such a use. It's accurate.
That's true. That's true.
But the data showed the data was accurate, but the data was useless.
Right.
So that's where DataBiologics has been proactive to say, we need to collect data that's actually relevant to an outcome that actually means something. Not just it's data we crunched and then we come up with something that we don't even know if it's valuable.
Right. That's what drew me to the group. So I really understand that gap between traditional tech and the big idea solutions and the technical data people. But if you don't have the real world context, if you haven't been in the room with the physicians, treating patients, trying to adopt new things, you just don't have the context of how does this data need to be first assembled and then delivered for them to understand it and be able to use it in real practice. And then at the same time, you need to have a whole bench of physicians who have different contexts, different experiences to be informing how that data is assembled and what exactly we need to get out of it. It's not enough to just have one clinician working with one IT person and coming up with a solution, because inevitably it doesn't fit the whole field. And also most physicians want to be physicians. They don't want to be IT people. And so you just get a total gap between the data science, the power that can exist there, and the lack of context and expertise that only comes through, this whole business is humans treating humans. So we have to have that context in order to know what to do with the data. And that's what makes us really special and unique. So we have both sides of it. We know what to do with the data, and we can bring it together.
Yeah, so you had mentioned earlier that in these big data EMR sets is that you may get some people to do some of this number crunching, but what does that take? A month later, you get an answer? Versus in part one, we talked about at a conference, literally like 24 hours later, we had an answer. And that's sort of the goal, right, of DataBiologics, is give you that real-time, real-world data answers to questions.
Right. Exactly.
So sort of with that, right, is that, we've had this discussions and how we go, but there are, I guess we'll say the classical researchers, maybe physicians, and you have the discussions I've had with orthopedists, and they want to look at disease modifying, right? So like, oh, this is just a pain management treatment, right? Just help someone's pain. Well, I mean, ultimately, as a physician, I don't treat a patient's knee arthritis. I treat the patient's suffering. Lots of people have knee pain. Lots of people have bad degeneration on an x-ray, but they don't really see a doctor unless they're suffering. And so the thing is, I always talk to people about post-treatment imaging, and there's the debate, and we don't really do it because on one end, the person's feeling great and running a marathon. If I do an image, their knee just looks just as bad, then they're going to psychologically feel bad. And if they feel, no better and their image looks a lot better, they're going to be like, well, what's wrong with me? My knee looks great, but why do I feel bad? So, if you can talk a little bit about, people in our database, we're talking about patient-reported outcomes, and that's the feeling, versus some of the skeptics and/or physicians or healthcare providers like, well, we need objective data. And I don't, some people believe one, some people believe the other. Is there a meld? What's your comments on that?
Well, I think the patient experience, and that's why it's so important. We have this very standard recipe because you need a lot of data in order to control for the noise that might exist on either end of it. So what we've done is we ask every single patient function, body part specific function, their perception of function, desired function, pain, mental health, and then we also ask about satisfaction. So did they get the result that they wanted, and how satisfied were they? The combination of those different measures for everybody, no matter the body part that they're getting treated, that allows us to kind of assess it on a standard index. So I call it our outcome success index. And because we have so much data, we can anchor those measures of change to patient satisfaction. So we can look at, well, people who say they're really satisfied with their treatment, well, what was the change that they experienced? And what's that minimal clinical important difference? So the MCID, when you're thinking about research, that connects to a positive outcome. And that goes back to what my comments were, maybe it was in our last episode, was, how are you going to train AI models? You have to point it to this is a good outcome, this is not a good outcome, or this is a gray zone outcome. So for us, it's really about that standardization and the full spectrum of the patient experience, their function, their pain, their mental health, their satisfaction with treatment. And when you have so many patients responding that they're satisfied with treatment and they're seeing a significant change in the clinical validated survey scores, well, it would be great to have even more objective measures. Maybe that's imaging, maybe that's something else in the future, maybe that's some other kind of result. But at the end of the day, if you're getting an improvement on any one of these scales and you're really satisfied with treatment, who's to argue that's not a successful outcome for a patient?
Yeah, that's the debate I have sometimes with people, right? And there are a lot of people, if you look at knee replacements, 30% of people have 5 out of 10 pain or more 1 year after the treatment. I would argue that's not successful, but sometimes that's why the surgeons say, well, I don't want to do your knee replacement until you're crawling in a wheelchair 10 out of 10.
Then you'll get to right. Then it's 5 is good.
Yeah, because even at 5, well, you're 50% better. What'd you want from me? It was better. And so I don't really think that's successful. And I'm a little bit harsh on my peers sometimes. At least I don't make everybody better either. But it's like, someone comes in, like my dad who's 95, and like, well, you're just old. I'm like, that's a cop-out, right? There are healthy old people and there are sick young people. So we just need to do a better job in medicine. So with those discussions, we hinted a little bit in the first episode about, how you can look at more than just orthobiologics, but talk a little bit about the platform, the company, the scalability, the areas of medicine it may or may not go into, and the vision you see maybe 5 years down the road.
Yeah, I mean, so we're already expanding beyond what your original vision was in orthobiologics. There's a whole new category of devices that I call energy devices. Things like shockwave therapy, electromagnetic transduction therapy. We're bringing on hyperbaric oxygen, which is a whole lot new category. We've just added neuromodulation devices, things like spinal cord stimulators. And there's a number of other areas that these treatments are being used in that are not musculoskeletal. So we're tracking sexual health, so erectile dysfunction, female pelvic floor dysfunction, urinary incontinence. There's some applications in ophthalmology and aesthetics that also use these treatments and are potential paths for us to expand. But really going back to my entire career in the device industry, where I worked with surgeons, everything from neurosurgery to orthopedic implants to robotic surgery, every single surgical specialty I've had really deep experience with, they all have a similar application, a similar need and questions when they're thinking about adopting something new, and our ability to quickly expand to these new areas of medicine is key, and we continue to do it. Since I came on board just 2 years ago, I think we were tracking about 60 products on the platform at that time. We now have 137 products on the platform, and almost every week we add new ones. Whenever somebody new comes onto the platform, they share with us, well, we do this and we do that. We recently added hormone replacement therapy, weight loss protocols as secondary treatments. So we really want to be able to support all of the different things that are coming into the channel for the physicians that are on our platform, and we can do that really quickly and really scalable. And then the other kind of side of the equation is, well, how do we start to make these insights accessible to patients and the network of physicians who are committed to evidence accessible to patients? And so in our evolution, we're establishing what I was talking about earlier, which was so lacking in this field, the consensus and the guidelines. What constitutes a good outcome, and how can we put a kind of a consistent structure and framework around what that is? How do we measure it? And then how do you achieve it? So the combination of the standardized approach to measuring that, and then being able to say, well, this outcome is a success. And these are the providers that consistently get a successful outcome with minimal variation in each of these treatment categories or each of these condition categories. So we want to really create a channel for patients to first be, just consumers of information, but ultimately consumers of, potential care through the network that we're curating and validating in a way that doesn't exist today. And in the parallel of big, current state healthcare only really exists in your insurance plan to some degree, but the insurance plans, the way that they rate and rank physicians is not purely based on outcome. It's many times it's based on cost. And so sometimes you're just going to get the lowest cost care, but it maybe isn't any good care at all. It's just what was, put forward to you because it's the cheapest, or it's most likely to tell you no on your care. So we want to do it differently and let consumers really be the judge and give them as much evidence as we can access in real time.
Yeah, I mean, it looks a little bit like, right, we heard, from prior governmental administrations, right, pay for performance, pay for outcomes, but they never had sort of a mechanism to quantify who's doing well, who's keeping patient populations healthy, which ultimately would save money and would improve people's health. So, I mean, this sounds like that's the information, number one. Number two is, you didn't speak to it. We've sort of, I think, talked about it around the edge, but we're looking at tracking novel outcomes, or DataBiologics is tracking that. What about the thoughts or scalability future about comparing it to current care? Does it supersede current care? So, as patients always say, well, when's it going to be covered by insurance? Insurers are managing risk, so they don't want to pay for a novel treatment and then pay for the standard thing because the novel treatment didn't work.
Right, right. Well, so actually we're really well set up to be really the leaders of that framework. There's some precedent already. I think that we're going to see more regional or commercial type payers would be the first to really take the real world evidence, and they do all the time. I have my past experience shows that when you bring data to regional commercial payers, that shows them that there's a potential benefit for it's usually around cost. If you can save cost for a payer by avoiding a more expensive or more drawn out care path for a patient, then they're willing to pay for that to stay competitive, because ultimately the payer, their customer, are large employers who fund their health plans. And so they're competing for that business, or they're directly competing for consumer business by saying, we can give you the most options for your care at the lowest cost. And how do you do that? Well, you have to control costs. To your point, it's about controlling the risk. And since we're not only tracking novel treatments, we're tracking traditional treatments too. We've got corticosteroids on the platform, and we're adding surgical interventions on the platform, so that there is a single place to compare side by side, even in the same practice, under the same umbrella. That will really start to allow maybe some of our larger groups to come to their regional payers, set a precedent, and using that data for contracting with those payers. But ultimately, really allowing DataBiologics and those that are on our platform, the members that today are contributing data, each of you guys in your own small practice doesn't have the size and the power to go bring, this data to a large payer and say, hey, this network of providers is consistently doing well, but we don't really want to all be in business together. Potentially DataBiologics can offer that, the power of, the size, the benefit of size, but not necessarily require you to be no longer independent, which I think is still a pretty strong vein in this space today, as opposed to maybe what we see in more mainstream orthopedic surgery.
Well, listen, I really appreciate your time. I think we've covered a lot of things. So we had part one, and this is part two. Hopefully all your viewers have really enjoyed it. So again, thank you for your time. And hopefully what's come through to the viewer is that, the people who are involved in DataBiologics as the clients, the physician clients, are really trying to figure out what's best for their patients. And so that's really what medicine, and how I got into it, is that we started to figure out is ultimately it's the patient. I mean, we understand there's costs and everything else, but if we can take this data, figure out what is the best treatment to apply to a specific patient, right? That personalized medicine, that precision medicine, that we can keep it cost effective, that insurers will want to pay. I think we ultimately get to our goal of radically changing healthcare so that we have a much better population and it's healthier. And, who knows what will happen if RFK is involved or the new administration or whatever, but hopefully there'll be some changes to try to make everybody healthier and save money in the United States.
Yep. And you can find our information on our crowdfund. It's wefunder.com/DataBiologics. And again, it's $100 minimum. So we want anybody who's supports what we're doing and where we're trying to take the field. We would greatly appreciate your contributions.
Yeah, we would. I just want to echo that we're trying to work for our patients, and if we get that data, if we get that support, then everybody's going to win all the way around. Thanks again. Have a great night, and thanks for tuning in, guys.